I'll be just briefly touching about the investigations, especially the imaging modality, what we do in the various rotator cuff tears. As we all know that most of the time we end up doing the plain X-rays. Sonography depends upon center to center. I wish Ashish would have been here. Oh, he's already here. Good morning, boss. Okay. How can we skip the sonography? Okay. And the MRI and occasionally CT scan in certain situations. I'll start saying that please always do plain X-rays. Plain X-rays are mandatory. Patients would keep the MRI on your table, saying that I've got 2 MRIs or 1 MRI, and it would show some kind of a rotator cuff tear, partial, full thickness, whatever retracted, but always do plain X-ray. It will give you certain findings straight away. As Mukesh was telling, calcific tendinitis, it is best picked up on X-rays, especially the type 1 where it is a heavy calcified mass. The type 2, which is all sparsed, you may not see, but you'll always see. The fractures, the superior migration, the cyst, the spurs, they are best seen on X-ray, and never to forget the arthritis. The grade 1 and grade 2 arthritis is best picked up on X-ray rather than actually an MRI. So it gives you far more important findings than straight away jumping onto the MRI. So X-rays are a must. And why do we do the X-rays? Sometimes you know that the diagnosis is rotator cuff tear, but why we need to do? Because we need to rule out any other cause of the pain. Small lytic lesions, it could be an infection, it could be a tumor. It's best picked up on an X-ray. It could be tuberculosis. The quality of bone, as Mukesh was telling, and the scenario was created, the patient had a rotator cuff tear with a pseudoparalysis. 6 to 8 weeks he kept on going to various, the native treatment and others, and that leads to severe disuse osteopenia. That disuse osteopenia is best picked up again on X-ray. If you don't pick up there, you may end up going to the theater with a smaller size anchors, which will not be giving you a good fixation, and there you need to have the larger size anchors. That's why again plain X-rays are important. The proximal migrations again are best picked up on when the patient is standing. Various arthritis, the various signs what we mentioned is spur and sclerosis. Yeah, you do see them, it does tell you that there is some problem, but it never helps you in changing your decisions. And if there is any metallic implant, what X-rays we need to do? You always do true AP. If possible, start making this standardization of doing only true APs. Don't accept the normal AP, because that helps in standardization. The outlet view and axillary view. Axillary occasionally. So the true AP is best to be started now so that it helps you in standardization. You can, every time the X-ray will look exactly the same. If you wish to measure these certain angles, it's easier if you have the standardized true AP view. The outlet view, which will help you in the figuring out the acromial spur. An axillary view is important, especially when it comes to rotator cuff. When we're talking about the arthritis or a type of a glenoid, in a routine, simple rotator cuff tear, the axillary view may not be very important. Yeah, occasionally you may pick up a mesoacromion. So what do we see on a true AP? You can pick up a fracture, quality of bone, cyst, calcification. These signs like GT sclerosis, dorsal signs, they don't really change your decision making. But yes, the lateral spur, sometimes you see a large lateral spur here, which you might have to remove when you're doing the rotator cuff repair in form of a lateral acromioplasty. The AHI, now AHI is the acromiohumeral interval. Normal acromiohumeral interval is always more than something like 8 to 14 mm, which is the same measurement of the distance between the radial and the ulnar stellate process. If it is less than 6, it tells you a infraspinatus tear. Anything more than that never tells you. Like supraspinatus tear can have something like 8 or 9 mm. Only when it is less than 6, you come to know that it's probably the infraspinatus tear. Now, regarding the repairability, it's a false concept. You can have an acromiohumeral interval less than 6 mm. In an acute situation, the tear will be still repairable. So, repairability is alone not decided based upon AHI. You actually need to understand the chronology of the events, and as Mukesh was telling, you have to do an MRI. If it's a grade 3 or grade 4 fatty infiltration with more than 50-60% atrophy with a very poor AHI, then yes, there is a repairability issue. But in acute tear, if you have an AHI of 3 mm and patient says, I never had a history of trauma or any other issue, and I was previously perfectly fine, then probably it's still a repairable tear. So here you can see the AHI is low. There's also a Samuelson Preto grade 1 or 2 starting the osteoarthritis, which is best picked up on an X-ray. So don't jump on straight away to the MRIs. Here again you can see the progressive arthritis in the 3 X-rays. The rotator cuff arthropathy is again one of the best thing to classify with the help of the true AP X-rays. The outlet views always do in all the chronic rotator cuffs. Acute may not be really important, but make a habit. Outlet view, start reading the so-called type of acromion, which remains at the moment debatable. Either I personally feel it's flat or it's a bit curved, but try to see this spur. You see this spur here. Now, this one should be left alone. This one you can take a call. You want to do very minimum acromioplasty, but this spur should be removed because most of the time they are anterior, and it is said that when the patient will do the forward flexion, that's the one which is going to impinge onto the anterior part of the rotator cuff, may jeopardize the rotator cuff integrity. So you can just make it a bit flatter and remove this off. And this is best seen on the outlet view. You can pick up with your experience on the AP view also. The axillary view, I personally do, as Mukesh was showing, when I am suspecting the calcific tendinitis, because if it is purely into the supraspinatus, you can pick up on the AP view. But if it is in the subscap and it is infraspinatus, then you are going to miss it because it is going to be overlapped by the bone. So there you need to have the axillary view. It's more important again in arthritis to see the amount of the glenoid erosion, how the humeral head is subluxating. Sometimes, the B2 type of glenoid can be very well picked up on the simple axillary view. So my indications are always do it. Never ever miss a plain X-ray. Even if patient shows you the MRI, go and get a plain X-ray first. Coming to the ultrasound, this is my first line of investigation. Generally speaking, in the rotator cuffs, I'll tell you why. It has got an overall high sensitivity and specificity to detect full thickness tear, a bit lesser for partial. It's cheap, it's very quick, no claustrophobia, dynamic, and you can repeat it as many as times because it remains relatively cheaper. There's no implant interference of any sort which happens in the MRI. And post-op imaging, it is one of the best thing to follow. I want to see after 2-3 years one MRI, fairly okay. The problem is operator dependent unless you have a wife at home who does that. Difficult to assess the cuff if patient is too much of the pain. And the biggest problem is you cannot assess the fatty infiltration and atrophy of the subscap, which is deep, quite deep. Cuff migration beyond the glenoid, it's a bit difficult to assess on ultrasound unless the sonologist is really experienced, and cannot assess other associated pathologies like labral tear or cartilage issues, especially if you're talking about the rotator cuff tear in a younger patient where there's a dislocation. So this is for me, it is generally a first investigation for all the cuff tears except where I know it is chronic, because in chronic, I want to know the fatty infiltration atrophy, which is best picked up on the MRI. In chronic, I need to accurately assess the fatty infiltration, muscle atrophy, and post-op imaging. This is my usual indication. And that's the key here is if you feel that your radiologist is very good, go and get the ultrasound done, and if you are in doubt, you can always correlate with an MRI. At the moment, MRI remains the investigation of choice for all the rotator cuff pathologies because the number of tendons torn, retraction, atrophy, fatty infiltration, bone cyst, undisplaced fractures, GT contusions which actually behave like a GT fracture but they are never picked up on X-ray, can be picked up on an MRI, the cartilage labrum. So overall entire information you get on an MRI when it comes to the rotator cuff pathologies. Plain MRI gives you almost, if you see the sensitivity and specificity, is almost same as of the ultrasound. So if you have a good sonologist, he can give you the similar finding. But when it comes to partial tear, it's also lower. The sensitivity is low. Can you change it? Yeah, you can do the MR arthrogram. But currently, with the 3 Tesla MRI, good, your clinical judgment as well, you don't need, because MR arthrogram sometimes tends to disrupt the virginity of the joint, and you don't want these dyes. Some people had serious reactions with these dyes. So it's more for when you want to know the cartilage and labrum pathology, probably it's a good investigation. Or a post-op repair, which you want to see whether the dye is leaking, with the smaller things which are not picked up. So MRI should be done 1.5 Tesla always minimum, coronal all three imagings, and this is the most important, as Mukesh was also emphasizing, you need to go till the edge of the medial part of the scapula. Sometimes they do the, the MRI poorly, you need to tell the radiologist that you need to go almost up to the device place of the scapula to get the sagittal oblique T1 section. CT scan, generally speaking, only in case of arthritis, if one is planning to operate to assess the glenoid retroversion, erosions, subchondral cyst, or if there's any associated fracture when you're talking about the GT displaced fracture. Now in GT displaced fracture, MRI is a poor investigation. It's a simple orthopedic teaching. When you want to see the fractures, do the CT scan. So with this, I finish my talk. Thank you.